everybody who's on time. Thank you very much for that. I appreciate it. Those were my closing words yesterday. Hope you enjoyed the evening in Brighton last night. Today we have our two keynote panelists. For those of you who don't already know, I'm afraid to say that Aditya Bharadwaj isn't going to be speaking today. We heard earlier this week that unfortunately his father is very ill and he's unable to travel until further notice. So he wasn't able to come today. But we have Insoo Hyun, who will be talking first, and then Margaret Sleeboom-Faulkner will be giving a presentation after Insoo. So first, to introduce Insoo Hyun, he's Associate Professor at the Case Western Reserve University in the US. Many of you will already know of his work. Associate Professor of Bioethics and Philosophy, and also Director of the Case Western Reserve University Stem Cell Ethics Center. He's been involved over several years working with the ISSCR, including in 2007 serving as co-chairperson of the ISSCR Task Force on International Guidelines for the Clinical Translation of Stem Cells, but also as a member of other committees associated with ISSCR. He's published widely in this area, which I'm sure many of you are already aware, including in his most recent book, Bioethics and the Future of Stem Cell Research, which was published by Cambridge University Press in 2013. And today, he'll be talking to us about the surprising complexities of stem cell tourism. Insoo, please.
Good morning. I'd like to thank the conference organizers and Margaret for the invitation to be here. I have no financial conflicts of interest to declare, although I'm always looking for some. I'm not. I'm going to talk with you about what I think are the surprising complexities of stem cell research. Now, these might just be surprising to me. Hopefully, they'll be surprising to you. I had been involved with the International Society for Stem Cell Research Guidelines for Clinical Translation. I was the co-chair of that task force, and one of the motivations for those guidelines was growing concern in the society about what they perceive to be the problem of stem cell tourism. Now, what I thought was really interesting about that work is that the more we try to define what stem cell tourism is, and what was problematic about it, it became very elusive. It became very difficult. Since that experience, I've come across some other issues that in my own research that I want to share with you. So, stem cell tourism is a term that I don't really like. I don't think that it quite does justice to what's going on. There are other terms people can use, medical travel. I mean, this is under the umbrella term of medical travel. And people have medical travel for various reasons. Some of them could be actually quite legitimate. The therapy is not available at home. So, for example, if you need a hematopoietic stem cell transplant for your child, you have to go to some centers of excellence in the U.S. to get that, right? So that's a stem cell-based therapy. It's travel, it's expensive. You have to cross borders, but we don't think that that's bad. There are other forms of medical travel where, again, it's not obvious that it's wrong. So some people may have to travel for elective abortions because it's not available in their locales. So they may have to travel to Sweden or places like that to get an elective abortion if you think that elective abortions are permissible. So it's not so much the travel that's necessarily bad. It's not always the case that people are paying. Maybe it's because the therapies are unproven. But there are also cases of people traveling for unproven or untested or unknown therapies in the U.S., for example. So face transplant at the Cleveland Clinic. Other sort of new therapies that hadn't been tried. A conjoined twin separation at university hospitals in my institution. We don't know if it's going to work. We don't know exactly what we're doing, but people have to travel for this. So it's very elusive, very elusive. Now, some may say that in the case of stem cell tourism, as is generally thought of today, the issue is quite clear that it has to do with fraudulent treatment. And here, I think in this sense, the metaphor of stem cell tourism is apt, right? Because you imagine here something like travelers going to a tourist trap, right? They're in unfamiliar territory. There are sort of inauthentic representations of real cultural artifacts there. And so then, you get consumer guides that say, go here, don't go there, right? Be careful of this fake artifact or this fraudulent good. So in that sense, I think stem cell tourism does capture that element of concern. However, I want to suggest that it's problematic. The term stem cell tourism is problematic for other reasons. Now, typically, the ISSCR and others have approached stem cell tourism in the following manner. So what are perceived to be the two big feeders for, if you think stem cell tourism is problematic, the two big feeders for stem cell tourism seem to be, on the one hand, lack of regulation, on the other hand, lack of patient information. And when you, as a society or as an individual, prescribe a certain course of action, what that prescription typically does is reveal your assumption about what the prescription of what the diagnosis of the problem is. Okay, so when you look at the prescriptions coming out of the International Society, it has to do with tightening the supply of stem cell tourism by cracking down on clinics and tightening regulations. Giving patients, or as we say in the society, arming patients with information, giving more consumer information. When you look at the prescriptions for how to deal with the problem, the diagnosis seems to be something like it's a marketplace problem, right? So you have fraudulent clinics, let's say, need to crack down on those and the claims that they're making. So you choke down supply. At the same time, you try to reduce demand. So you inform patients and give them things like, we provided a patient handbook that's been translated into multiple languages. Patient information, consumer information, crack down. I think this marketplace approach is limited in many ways. So this is sort of my thinking further after the guidelines came out in 2009. One of the obvious reasons why I think this sort of consumer-based marketplace problem framing of stem cell tourism, the reason why that's problematic, is that I think, I know that in many, many cases, the patients that travel are children taken by their parents. So pediatric patients taken by parents who, I think that the model of consumer awareness, consumer information, consumer autonomy doesn't quite fit well in that situation, because decision makers are making decisions on behalf of another patient whose body is not the same as the decision maker's body. So I think that the diagnosis may be a little bit off. Now I'm going to present in the remainder of my presentation other reasons why I would urge us to go away from the consumer marketplace framing of stem cell tourism. The first is to look at it more from the standpoint of the patient's own disease experience itself. Okay, so when we look at it as a marketplace problem, we're sort of looking at it from the standpoint of a regulator, consumer information, crack down on fraudulent behavior. But when you look at it from the standpoint of the patient, especially if you draw on the literature from nursing and family medicine and hospice and end-of-life decision-making, patients who have very serious, intractable medical conditions that are often chronic experience their reality in a very particular way. So what I think is a possible other feeder into stem cell tourism is what I call the combination of therapeutic hope and spiritual distress. Now, I want to begin with therapeutic hope. People sometimes confuse what I call therapeutic hope with therapeutic misconception and therapeutic misestimation. So therapeutic misconception is the idea that a patient enrolled in a clinical trial may be under the wrong impression that they are being involved in clinical care and they don't quite understand that this is a study for which they might be randomized into a control group or the experimental group, that the purpose of the clinical trial is not to necessarily help them, but it's to advance knowledge. So therapeutic misconception is a faulty belief that somebody has in the context of research. Therapeutic misestimation is where somebody misestimates the likelihood or the size of possible benefit to themselves and underestimates the amount and the likelihood of harm to themselves. Both of these, therapeutic misconception, therapeutic misestimation, are again in the context of research participation, and they're cognitive, sort of, they're false beliefs that you can try to correct for with better information. Now, therapeutic hope is not the same as those. For one, it's not in the context of research, it's within the context of clinical care. That's one major factor. The other one is, I think, is less cognitive and tends to be more emotional. When you look at the literature on therapeutic hope, or the literature on hope coming out of family medicine, nursing, the other literature outside of stem cell ethics, it's very rich and very interesting. People report about how patients and individuals who have therapeutic hope have a particular architecture to their hope. Okay, so a lot of times people think, well, hope is just like mere wishing, like, oh, I hope that I get better, I hope I get cured. It's not passive. Therapeutic hope understood in these contexts is very active. So it has the following architecture. First, you say, I have a goal. Second, you identify pathways to that goal. One of them might be a stem cell-based therapy. Okay? So the goal might be, I want to be less of a burden on my family, I want to survive, I want to X, Y, Z. They identify a pathway to that, maybe travel to a stem cell clinic for a therapy. And then thirdly, besides goal, pathway, thirdly, you have to believe that it's within your power to do that, right? I can achieve that, I can travel, I can take something proactive, I can take a step. So it's not passive. It has that structure, 1, 2, 3. It's in the positive psychology literature, it's well documented. That's the way people in therapeutic hope think and engage, remain engaged with their own future. They sort of invest and engage in their own future in this way. So what happens is if you deny them one of the pathways, you say, well, no, you can't, you shouldn't go to a stem cell clinic, or you shouldn't do such and such, without replacing that pathway to their perceived goal. Or if you take away their belief that they actually have the power to pursue any of these pathways, the risk is that they can then fall into what's called spiritual distress. Okay, so often you'll hear patients say things like, well, all the doctor's telling me is no, don't do that. And if I want to avoid slipping into spiritual distress or getting depressed about it, I'm still going to then, I have to do something. I feel like I have to do something and I have to go forward. So spiritual distress, sometimes people, when I talk about this, sometimes people get the wrong idea. I'm not talking about religion. When we talk about spirituality in medicine, it's much broader than religion. Sometimes people find spirituality through religion, not always, but spirituality is a broader notion. Spirituality is an idea that, it's how the individual finds meaningfulness in his or her own life. And they can get that in many different ways, through religion, connection to nature, art, music, involvement in the community. Now what happens with severe illness, and this is again in the medical literature, is that illness has a way of disrupting how you find meaningfulness in your life, whether it's isolation because you're very ill, you can't engage in the community, you can't even go to church, let's say, or you can't do the things that normally give your life meaning. Or it could also enter in, spiritual distress could also enter in if you're a very religious person, and you say, well, why is God doing this to me, or what's happening? So there are different ways to sort of frame what is the meaning of my experience. Right? So if you look at the patient's disease experience itself, they try to frame it in certain ways. Is there any purpose behind this? So the fascinating thing about these two, and I've written about this in Cell Stem Cell, this was June 2013, is if you take that literature that I think is very well established and very interesting to me personally, the therapeutic hope literature, the spiritual distress literature, that's one big missing element, I think, to discussions about stem cell tourism. Okay, so the consumer model that says it's basically the only obligation is that the provider, as the seller, gives truthful information, and then the consumer, the patient, as the buyer, has to have assume the risk of, right, buyer beware, assume the risk of purchasing that thing and has to get educated about it. That model misses this element of, I think, patient behavior and patient disease experience. Okay, when you go to buy something in the store, you're not in a state of spiritual distress, or you don't have therapeutic hope. you have a consumer preference you want to satisfy, and you've done your research and you're willing to spend money. So I think this whole element of patient life is ignored in stem cell literature. So what's also fascinating about this, and I actually talked a little bit about the quote I started off with George Eliot says, but what we call our despair is often only the painful eagerness of unfed hope. What that means is they're related in a really interesting way. I mean, spiritual distress is a result of loss of therapeutic hope, and often therapeutic hope is a way of trying to stave off the arrival of spiritual distress. Now, how to deal with this? It's very problematic in medical education. I mean, I teach in the School of Medicine, right? When you poll patients, 70% of them or more wish that doctors would talk about spirituality issues with them. I don't mean religion here. When I talked to the chaplain of our hospital, he says in his nearly 40 years of experience, he said religion came up 4 times. What does Catholicism say about it? They want to talk about meaningfulness of the disease experience. 70% want to talk about that with their physicians. 10 to 20% of physicians want to talk about it with their patients. There's a big mismatch. How to get this going in the clinic is a major challenge. How to teach people to attend to these issues in medical school education, that's a big challenge. There's nothing in the curriculum that deals with that. So that's the first, I think, complexity. Okay? One of the reasons why you want to get away from the consumer model. The other complexity is medical professionalism. So we talked a lot yesterday about stem cell treatments, and a distinction I want to draw for people is, regulation, let's say FDA level regulation, only deals with complex biologics. These are things, cells, that are typically going to be donor to recipient. It's a allogeneic graft, and it's highly manipulated. Now, in the case of autologous transplantation, where you take the patient's own cells and you transfer it back into them with minimal manipulation, FDA has no governance over that. That's considered a medical service. So typically what happens in the stem cell tourism debate is people will argue that medical services should be under the aegis of professional judgment, physician's judgment, and that the regulators need to stay away from that. I think that's correct. My view is that's correct, but it doesn't then mean that anything goes in the provision of medical therapies as a bedside service for using the patient's own cells back into them, because under that approach, you still have the norms of professional medical ethics, clinical ethics, the stuff that we teach our medical students in their medical education. So one question that's really, I think, provocative is, in the case of unproven stem cell therapies, should patients be charged? Should physicians offer this to their patients? My view that I published with Megan Muncie is no, but obviously this is open for discussion later today after I speak. It's no, because if you look at the standards of professional ethics, it's very difficult to justify this type of practice. So let me give you an example. So in 2002, there was something called the Physician Charter that was published simultaneously, by the way, at the same period, both in the Annals of Internal Medicine and in the Lancet. And the Physician Charter was written by 3 groups: the American Board of Internal Medicine, the American College of Physicians Foundation, and the European Federation of Internal Medicine. Now, what they said in this one-page charter was just a restatement of basic professional commitments and obligations. Primary up there was the commitment that the physician in the Physician Charter makes a promise that he or she attend to the best interest of the patient above their own personal interests. Now, going further along, there's also a stated commitment to medical competence in what you're doing to your patients or for your patients, a commitment to scientific knowledge and evidence, that you only provide evidence-based medical care that's backed up by scientific research, and that you avoid at all times financial conflicts of interest, that you not that you not put your own financial interests above the well-being of your patients. Now, I can get into a lot more detail about what these statements actually mean, but I think taken in totality, it becomes difficult to justify cases where people don't have the actual scientific backing for what it is that they're proposing, that there is no body of scientific knowledge supporting the belief that it could help your patient, and that they're doing this for profit. So I would add to the first two, these bottom two arrows, right? We have increasing complexity. We have therapeutic hopes, spiritual distress, all the difficult issues of how to deal with that with patients. Then you have arguably lack of medical professionalism, or the difficulty of squaring practices that you see in stem cell clinics with standards of medical professionalism. Third layer of complexity is medical innovation. Now, despite what I just said about medical professionalism and science backing up what it is that you're providing for your patients, ISSCR and I believe that there still has to be some room for medical innovations outside of a clinical trial system. So this is where it gets into a very difficult balancing act. You have to have some room for innovative medical care, and at the same time not condone bad practices. So Oli Limbaugh and I, who he was the other co-chair of the task force, ended up writing up this topic in an issue in Science in 2009. Now, what we tried to do here in this piece is try to say what's different between what people complain about, stem cell tourism, and responsible medical innovation outside the clinical trial system. You know, I've had people tell me, other bioethicists tell me, I can't think of any other context outside of a clinical trial system where it would be responsible ethically for somebody to put in to a patient an untested stem cell-based product or therapy. And I thought that's a little bit too narrow, because it overlooks how a lot of things develop in clinical medicine. So let me back up a little bit and just point out that we also talked yesterday a lot about stem cell therapies without really breaking it down into the enormous array of complexity that's underneath this general term stem cell therapy. Stem cell therapy is not one kind of thing. It's an enormous array of different types of things. So these are just some of the examples of how one therapy could differ from another. You have different sources of cells, right? You have somatic stem cells, you have now derivatives of ES cells, iPS cells, possibly other reprogrammed cells. So you have patients' own cells back to them, you have donor cells, you have master cell lines, and you have the immune compatibility issues with the master cell lines. These cells could be genetically modified or not. They could be for autologous or allogeneic use. They could be for the patient back into the patient or donor into recipient. They could be homologous and non-homologous use. Homologous use would be, this is where the adult stem cells are normally found and they normally operate. Be put back into that system, or non-homologous would be outside of that system where they're normally found, where we don't really know exactly how the cells will behave in that context. Administration could be systemic or local. Systemic would be just in your blood system, okay? And then the concern is whether in the filtering organs, like the liver or whatever, that they'll collect there, or local administration. If it's local administration, it might be more surgical, right? So injured heart, locally administer, transfer, transplant those there. Cell dosage, cell frequency, we could also add, stage of the disease for the patient, early stage, middle stage, late stage. So there are all these complexities. I think the one that's really interesting to me is the systemic or local, okay? Because systemic intervention is more like the cells kind of act a little bit more like a drug. They're sort of supposed to be transient. They sort of stimulate endogenous healing responses, and then they're out. Okay, so it kind of is like a drug in a way. The local administration is much more like transplantation, much more surgical. So if you keep that in mind, then you have an enormous array of different options, and some of them align more toward the pharmaceutical drug paradigm, and others, many more, start to edge more toward the surgical paradigm. The further they're along the surgical paradigm, the less comfortable the fit between a stem cell-based therapy and FDA clinical drug trials procedures. So if you look at, in the history of medicine, the development of surgical or transplantation interventions, very, very few of them, as was noted yesterday, very, very few of them ever went through a clinical trials process. In the last 40 years, only 10 to 20% of surgical innovations happen through a clinical trial system. Some of them never went through it. Cardiac transplant, laparoscopic surgery, deep brain stimulation, just goes on and on and on. Were developed in the context of innovative clinical care for patients and not generalizable knowledge with IRB review, and then you have, control group, experimental group. They didn't develop that way. So if you have a stem cell-based therapy that looks more like that, there needs to be a different pathway to sort of regulate and look at the ethical development of that. Just because it developed that way historically doesn't necessarily mean it was always ethically right way. And in fact, the biggest example of a stem cell-based therapy today was hematopoietic stem cell transplantation, or bone marrow transplantation, and that never went through clinical trials, and that actually has some pretty awful outcomes during the process. So the other way in which stem cell-based therapies could develop outside of a clinical trial system would be off-label use. I'm not going to get too much into that, but that's where you have an investigational product that's gone through at least phase 1, and then with the agreement of the investigator, a physician could apply to the FDA and ask for almost like emergency use for a patient, a limited number of patients, and they can charge patients for that. So there could be possibly some period where you have a stem cell-based investigational product and it enters in that way to patients' bodies. I think the more likely scenario is, sorry, that was expanded access. The more likely scenario is off-label use. So off-label use is very widespread in the US. I know that it's much more controlled in Europe. The rules are much tighter. But in the US, as soon as the FDA gives approval for a drug, it gets a label. It says, here's the indication, here's the dosage. But as soon as that gets released into the medical marketplace, any practitioner can use that and use it in a way that they think could possibly help their patient without further review by any other kind of committee. And that's the part, that's medical service, that's the part the FDA does not govern. So imagine any sort of complex biologic that finally gets approved for some sort of indication from a stem cell-based company, when it's out there in the marketplace, guess what? That's the tool that people will then use for whatever indication they think is appropriate. So there's nothing to govern over that. So what we did in the international society is we said, well, look, we want to preserve some room for medical innovation outside of clinical trials. And in fact, there's no way to get around that once things start to get developed. There's no way to prevent people from using that in their own way. In fact, whole subspecialties are based on off-label prescribing. Pediatrics, oncology, psychiatry. You wouldn't have those fields if you couldn't do off-label prescribing in the US. So we know it's going to happen when you start releasing products. Okay? So what did we say? Well, we say, to try to separate out problematic stem cell person, we still haven't quite defined what the heck that is, but to sort of separate out bad practices from good practices outside of the clinical trials context, we say there should be some guidelines. One is there needs to be some sort of written plan of what you're going to do and your rationale for that, and that has to get reviewed by domain experts who have no stake in the outcome of that. So somebody needs to review this. The focus has to be on patient care, not on research. This is why the IRB structure is inappropriate for oversight. IRBs only look at a specific set of issues within the context of research, but these are not the same kinds of questions you're going to ask in this context. Okay, so a review process that attunes more to patient care, patient follow-up, monitoring is the third one. The fourth one I forgot to put up here, that is, what we say in the guidelines is after experience in just a few patients, there should be some proactive steps being taken by the clinician to initiate some sort of data collection, movement towards some sort of clinical trial process. So that's all in our guidelines. That happens to actually coincide. I didn't realize this until after the guidelines came out, that right around that same time, 2 other groups came out with very similar recommendations for innovative care. One was the Society of University Surgeons, who said for surgical innovations, there needs to be a written plan that gets reviewed by people who are domain experts, etc., and that focus needs to be on patient care. University of Pittsburgh School of Pharmacy also says in their School of Pharmacy, at their hospital, they have to approve of off-label use of drugs through this sort of committee review. Right now in Cleveland, where I am, the Cleveland Clinic, and also my university are starting what's called the Cell Therapies Review Committee. This is very broad, it's not stem cells only, but Cell Therapies Review Committee, because we realize there are people at Cleveland Clinic and there are people at university hospitals that do things that just people in leadership have no idea is going on. And there's no review of what it is that people are doing and why they're doing it and Why do you think it's good? Okay, so again, this is not research, this is clinical care, and the important distinguishing factors in research are supposed to have clinical equipoise. You're not supposed to really know one way or the other which is better, standard care or the new therapy. In this case, for patient care, you better not have clinical equipoise. You better really believe and have reasons for thinking this will help them to recommend it to them. So somebody needs to take a second look at that. So we have add here medical innovation. The last thing I want to just raise is another complexity that just came up this month. Okay, so in Japan, the pharmaceutical laws this month were changed in a major way. Let me just point out 3 of these changes. So one is that they made regenerative medicine products a separate category from drugs, devices, and other biologics. And that this is the big one, they introduced a conditional approval system for regenerative medicine products that have cleared early safety trials and shown some preliminary efficacy signals. These products may then enter the market while efficiency data are collected. So just to summarize what's happening here, in Japan they said, we have some products that don't fit easily into drugs, devices, other biologics. We'll just call them regenerative medicine products. For these products, you can actually put them into the marketplace once you've shown at least that they are safe or not terribly harmful for humans, and maybe have some signals of efficacy. This is probably going to be in your animal models that it has some efficacy. And along the way, we'll try to collect data about efficacy. Do you understand what's happening, right? So we don't really know if it's going to help you. We don't really think it's going to hurt you. So we'll just go ahead and start delivering it to patients. And along the way, we'll try to then keep track of whether or not it is efficacious. The big other introduction, this just was announced November 5th, so just a week ago, that the National Health Insurance Association announced that these conditionally approved products will be reimbursable. So what's really interesting about this is, in Japan, if this all plays out, you have unproven in efficacy, unproven stem cell-based products being introduced very early into the medical marketplace for consumers to use. Let's say we have good information and all that, okay? But the regulatory structure is allowing this. And they can also get paid for this, right? So they get reimbursed. Now, the reimbursement in Japan works where the government pays 70% of the cost and the patient pays 30%. So 70% of the cost of efficacy development of these will move out of private industry and move to then become a burden on the public health system and on patients. So you can debate whether or not you think that's fair, you can debate whether or not that's good, or what exactly the rationale is for going forward with that. So we have many surprising complexities behind stem cell sourcing. The original 2 red arrows don't even touch the full array of complexity. Now this is my last point, I just want to point out, I think that the arrows are interrelated in a really interesting way. You have threads of thought running through all of them. One is medical professionalism. Right? So what do we mean by that? How does medical professionalism interact or intersect with therapeutic help and spiritual distress? Is there a commitment or is there a need for medical professionalism to take more attention to that, pay more attention to that? What does medical professionalism say about responsible medical innovation for patient care? Right? So you're not trying to gather data, you're trying to do the best you can for your patient. And what about regulatory structures that then start to sort of push people back toward almost like a consumer model of a doctor-patient relationship? So I think there's this, in my view, this battle between consumerism and professionalism, which isn't simply reducible to consumerism, and that's the continuum of complexities. That's all I have.
Insoo, thanks very much for what I thought was a really vast but very clear outline of some of the complexities in the field that we all work in. What I'd invite is for people who have questions of clarification to ask them now, but what we're going to do is to move after that on to hear from Margaret, and then we'll have both of the speakers on a panel to hopefully answer wider questions and have some discussion. But are there any specific questions to Insoo before I invite Margaret up to talk? Yeah.
Thank you for your wonderful lecture. How could you determine the success of the medical innovation? How would you determine the word success? Because you're talking about the outcome of the innovation and everything. How would you say that this is success?
I don't know. I don't know how you would define success in that case, right? So one would be sort of, so you can define it in clinical terms, like patient outcome and all that, right? But in medical treatment, this is an interesting question. So like, what is successful medical treatment?
Right.
So there are different ways of, is it patient satisfaction? Is it quality of life as the outcome? What is it, functional improvement? So I don't really know which is the best approach. In the case of how do you know that this system is working well? I don't really know well enough because it's just getting started, for example, in Cleveland and these committees, right? So we don't really know yet because we're just forming them exactly how it's going to play out, what if any differences it'll make in quality of patient care. Definitely what the aim is to have the provision of these untested or innovative or new therapies at least have some sort of oversight and some institutional awareness, right? Because I think a lot of this is sort of driven by the legal department of these hospitals, but a lot of concern is that something bad could happen, families could complain, and then the institution realizes that the clinician was doing this, and it brings everybody into it. So that's one of the motivations. But that's a very good question. How do you know it's working? One thing that you might say preliminary is just that that it's working in the sense of there has been good discussion and openness and transparency about what clinicians are offering to their patients, and in some cases, some of these proposals, let's say, that otherwise would have gone forward in the alternative world, were maybe corrected, improved, or even stopped because of the concerns of the peers. The other thing you might want to add that I didn't mention today was the medical innovation approach. It's very challenging because what we're finding in Cleveland is who are going to be these people that sort of do this dispassionate review? They're going to be all the people who are sort of colleagues of this individual. And so how objective can they be? That's going to be an ongoing concern. So it's just, it's an evolving new area. So, I wish I could tell you more, but we're just starting.
Well, the reason that I asked this question because I realized that when the heart transplant is coming to the experiment, the patient survived for 1 day.
Right.
So is that success or is it failure?
Yeah.
It's the same. I think it's applied to the new innovation.
Well, I think if you're trying to do the best you can for patient care, then that was a failure, right? But if what you're doing along the way is you're gaining experience to maybe improve your approach the next time, then if you learn something, then that could be a success, right? Good question.
Thank you.
You spoke something about the United States and what's happening in Pittsburgh and Cleveland. You also mentioned that the US FDA, which I'm aware of, says that if you're doing autologous, it's not in their purview. Could you just clarify what is the exact situation of status of cell therapy in the United States? Because when recently I was traveling, I went out of New Jersey airport, there was a huge advertisement billboard that spoke of cell therapy for knee. And it was this big ad outside the airport. So they were advertising cell therapy for knee. What is the status in America? The reason I'm asking is for some reasons, good or bad, America sort of sets the trend for what the world will follow. And what happens in America, and one of the reasons why cell therapy has taken sort of like a back seat is because of George Bush's original ban. So could you just clarify what is the present situation?
Yeah. So I can tell you what the FDA's position is on this. What they say is for the clinician to use the patient's own cells without FDA oversight, they have to be minimally manipulated under non-proliferating conditions for 48 hours, under 48 hours. So out of the body, less than 48 hours, you just clean them and put them right back in, and you have to put them back in to where it has to be homologous. So it can't be, from one system to a totally different system. So if they're more than minimally manipulated, if you've done something to expand them in culture, or if you've kept them out of the body for longer than 48 hours, or if you put them somewhere else in the human body where they aren't normally found, that for any one of those reasons, the FDA will come in and try to prevent that, say, they have jurisdiction, that you have to have an investigational, application, new product application, etc. There was a legal fight between the FDA and a clinic in Texas, and FDA barely won that. But what was interesting was, people don't notice, but what they won on was they said one of the reagents that they used was FDA controlled, and the FDA didn't give permission for them to use it, and apparently it was something they had to use for that. So they didn't actually settle the issue of, homologous, non-homologous, any of the three I listed, right? expansion, time outside the body. It wasn't actually settled on any one of those. People think maybe it was, but it wasn't. It was on this other technicality. So I think it's going to get challenged again in the future. That's not settled.
No, but today, if a surgeon wants to, let's say an orthopedic surgeon wants to put in the knee, or a neurosurgeon wants to put this in the spine, autologous,
would he, by American medical regulations and law, be free to do so?
Yes, that's why Cleveland Clinic wants to have its own committee,
Okay.
because they are doing that.
They're doing that.
Yeah, they're I mean, a lot of,
And they could charge for it.
what's that?
They could pay, I mean, they
Yeah.
could charge for it.
Yeah. So that's why other societies and local institutions are trying to come up with something. What's interesting is they all sort of have a universal theme or universal approach, which is sort of like some sort of more dispassionate review about the plan, the rationale for the plan, the patient monitoring, the informed consent auditing. You want to really make sure that they understand. So a lot of times patients don't know, like, we've never tried this, or we don't really know, there's not much experience. They think, well, this is Cleveland Clinic, this is my doctor, they know what they're doing. Not always true. So the informed consent needs to be rigorous, and somebody else needs to take a look at it. Now, the real problem that we're finding locally is, well, who are these domain experts locally that are going to do that? Because you can imagine lots of other clinics, right, where people say, well, okay, well, we all looked at it, and we all think it's fine, and everyone's concerned about that entire clinic. So the other thing that you might try to add, and people, have concern about this, is that it ought to only be tried at institutions that have what's called field strength in the area, so like a relevant expertise in sort of like similar procedures, like with liver transplantation or something. Then you get into a whole debate because you added another rule, like how to interpret that. Well, what is field strength? How do we define that? Yeah, but anyway, short answer is nothing stops them, so that's why some of these places are trying to come up with internal procedures.
Actually, define
There's two questions. Sorry, there's another question over here. Sorry.
So well, we can have discussion about
Yeah,
this
exactly.
as a panel.
Thank you.
Thank you very much for your interesting presentation. You said that therapeutic hope might be an antidote to spiritual distress, but isn't the relationship more complicated that therapeutic hope, as it were, could also be lead to an increase of spiritual distress?
It could. I mean, the way it's defined in the literature is sort of thought to again, sort of, it's a way of the person remaining engaged in their future, right? So being committed to looking forward to going on, and yeah, I mean, I tend to just conceive of it as sort of a positive striving, and the spiritual distress is more sort of like the despair of not finding any more meaning or any more reason to go on, right? So I'm trying to appreciate what you're saying, but I want to just keep it separate for convenience. Yeah, but anyway, what's really fascinating about the therapeutic hope approach is when you look at the hospice literature, when you look at end-of-life care, it comes up a lot, and what happens is patients who are told by the doctors there's nothing more we can do for you, they'll go to alternative therapies or herbal therapies. And I think a similar sort of approach might be taken. This has to be studied empirically, okay? But similar type of thing could possibly happen. This is the hypothesis. Could happen with stem cell-based therapies, right? So you say, well, the doctor says there's nothing more they can do for my MS. This is the best that Western medicine has to provide, but what about these innovations we're doing in other countries? I want to just try that. So again, they are, if you don't identify a productive pathway for them, they'll find another one to meet their goal. Whether it's disease amelioration, not being a burden, wanting to return to functioning, whatever it is, the goal, they end up doing that. When all of them get close up, and that's when you get the spiritual distress.
Thanks. We've got one last question. I'm afraid we're going to have to move on after that. But
We can move it later, maybe.
okay, sure. Why did you ask it after Margaret?
Well, there are many points that would deserve a very thorough discussion and this very clear presentation. I'm particularly glad you touched upon the hope issue. You presented this as an alternative way of looking at the problem, different from the conventional marketplace approach. It seems to me, though, that there is sort of a gap in our clear definition of what hope is. The harder I think about it, the more I come to the conclusion that there is one definition of hope that comes from evidence-based medicine. That definition of hope is essentially a probability. as a result of clinical trials, you know that use of drug A in condition B is going to give the probability C of getting a patient response. So that kind of hope is actually, in all reality, based on certainty. Then there is another definition of hope, and I think that that is the one that introduces a word of caution in making consideration of hope alternative to the marketplace approach. We have to be clear that hope itself is a commodity on the marketplace. So that is what is in fact being marketed to patients. And that raises a number of other issues, which we don't have time to touch now, but this is a specific point. There is the marketing of immaterial commodities, which is an inherent part of the problem. The other thing you touched is spiritual meaningfulness. I, in the past, have had plenty of experience of dealing with patients with diseases for which there is nothing to do. The surprising experience for a physician in that kind of interaction is how often patients are clear that their role in the endeavor is not just for themselves, is for the fact that they're contributing to clarify how to treat their disease in patients that are yet to be born. So this meaningfulness of the patient participation as a way to cure spiritual distress, as you put it, hits on a very specific ethics point, which is self versus non-self. And it seems to me the whole field is dominated by an idea of ethics in which the only core of any ethics is self. But this is not, has never been, and never will be the ethics of medicine, which is, by definition, non-self.
Yeah.
Can you?
Yeah, well, I want to start by, I agree with everything you said. And in fact, the first point about hope being the commodity, I do get into that a bit in this article, because I think that what's happening is the purveyors of stem cell clinics will find an opportunity there, with patient hope. Now, the other thing that's I think very interesting is in spiritual distress, people feel removed from communities or connectedness to other people. And what you find often in some of these clinics is they have these online forums or chat rooms that they provide for their patients that have been there, and they get together and they continue this sort of community of people, patients who travel there, so they kind of get a sense of community connection through that community. So that's one, I think, interesting phenomenon that I make note of in the article. The other one about meaningfulness of your disease experience and kind of like attaching that to sort of, an altruistic sense of providing benefit for other people. I mean, that's very strong when you look at interviews of people who participate in stem cell-based clinical trials. So the example I have in mind is they interviewed two people who are enrolled in the Geron now, sold by Geron, spinal cord injury trial. And both of them said, they're both very young because they were car accident victims, they're in early 20s. One is teenager still. They both said, I was looking for a reason for why this happened to me, or why did God make this happen? And the first person, the boy said, I think it's part of God's plan that I got this injury and that I have to participate in this trial. The other one, the last person to get enrolled, Katie, she said in an interview, San Francisco Chronicle, I'm looking for a reason for why this happened to me. Maybe this is to help other people in the future who have spinal cord injury. And so, like, they again find meaningfulness of their accident by thinking that what they're then doing by participating in a trial or getting a therapy is eventually helping other people in the future or recovering meaning for themselves about their own experience. So yeah, I definitely see examples of what we're talking about.
It's really fascinating. Thanks very much. Perhaps we can continue this after we hear from Margaret Sleeboom-Faulkner, but Insoo, thanks very much for that talk. I'll hand straight over to Margaret. Yeah.